Hi, welcome to Approach to OBGYN. Today we'll be discussing gestational hypertension and preeclampsia. Gestational hypertension is one of several causes of hypertension in pregnant women. Gestational hypertension is defined as a systolic blood pressure over 140 and or diastolic blood pressure over 90 in a previously normal-tensive pregnant woman who is 20 weeks or greater of gestation and has no proteinuria. It is considered severe when systolic blood pressure is over 160 and or diastolic blood pressure is over 110 on two readings taken at least 6 hours apart. When proteinuria is present, the hypertensive disorder is then classified as gestational hypertension with preeclampsia. Preeclampsia is the second leading cause of maternal death worldwide, second only to postpartum hemorrhages. The exact cause of gestational hypertension is unknown. However, the most commonly accepted theory suggests that it is caused by abnormal trophoblast invasion, which in turn leads to endothelial cell dysfunction. This leads to an imbalance of thromboxane and prostaglandin and leakier blood vessels. The risk factors for gestational hypertension can be divided into maternal and fetal in origin. The maternal risk factors include prima gravida, which accounts for about 80 to 90% of gestational hypertension, first conception with a new partner, past medical history or family history of gestational hypertension, diabetes and chronic hypertension, antiphospholipid syndrome, and being extremes of maternal age under the age of 18 or greater than the age of 35. The fetal risk factors that contributes to gestational hypertension includes intrauterine growth restriction, illegal hydramnios, multiple gestations, and fetal hydrops. Some people suspect that the abnormal trophoblast invasion is an immune-mediated process where there's the immunological intolerance between the maternal and fetal DNA. This would help explain the increased prevalence of gestational hypertension in prima gravida and first conceptions with a new partner. Differentials to gestational hypertension includes pre-existing hypertension that developed before 20 weeks of gestation. 90% is considered essential hypertension with no identifiable cause. The remaining 10% are caused by diseases such as pheochromocytoma, Cushing syndromes, and renal problems. Gestational hypertension can develop into pre-eclampsia when there's proteinuria or when one or more of the red flags is present. We'll be going over the red flags on history in a later section. HELLP syndrome is an obstetric complication that is present in 10 to 20% of women with severe pre-eclampsia. The exact cause of HELLP is unknown, but general activation of the coagulation cascade is considered the main underlying problem. HELLP syndrome includes hemolysis, elevated liver enzymes, and low platelet counts. It is always important when approaching any pregnant woman to take a detailed obstetrical and gynecological history. This video will only cover the red flags that warrant urgent investigation. Worrisome symptoms on history include epigastric or right upper quadrant pain, and this is due to the stretching of the Glisson capsule of the liver due to hepatic swelling or bleeding. Headaches that are often described as the worst headache of my life, and vision changes such as scotoma are due to cerebral edema. Shortness of breath or chest pain are due to pulmonary edema, and convulsions, also known as eclampsias, are also due to cerebral edema. There are several maternal conditions that are considered red flags. The HELLP syndrome, as previously mentioned, is one. Left ventricular failure, pulmonary edema, oliguria, elevated creatinine, and cerebral hemorrhage, all indicated concerning end organ failure of the heart, lungs, kidneys, and brain. An eruption would indicate damage to the placenta, and DIC reflects the systemic nature of the disease. The fetal conditions that constitute red flags include intrauterine growth restriction, illegal hydramnios, umbilical artery end diastolic flow, which is absent or reversed, and intrauterine fetal death. A focused physical exam in approaching gestational hypertension and preeclampsia must include the general appearance and vitals. The vitals should include maternal heart rate, blood pressure, respiratory rate, oxygen saturation, temperature, and fetal heart rate. A head and neck exam should include the cranial nerve exam to identify evidence of stroke and fundoscopy to identify papilledema. A respiratory exam listening to abnormal air entry and crackles can show pulmonary edema. An abdominal exam should include testing for right upper quadrant or epigastric pain that indicates liver capsule distension, the measurement of the symphysis bundle height, and using the Leopold's maneuver to identify fetal position and presentation. You should also check for signs of hyperreflexia and clonus, which are common neurological presentations in preeclampsia. Since preeclampsia is a systemic disease, the blood work needed in the workup becomes quite extensive. CBC with blood film, AST, ALT, LDH, and bilirubin will screen for HELLP syndrome. Creatinine and uric acid abnormalities will identify renal failure, and 24-hour urine samples will help differentiate between gestational hypertension and preeclampsia. The fetal monitoring that are needed includes a non-stress test, a biophysical profile, ultrasound, Doppler flow studies. These will help identify signs of fetal stress and the need for an emergent cesarean section. The only treatment for preeclampsia is the delivery of the fetus. This is not always possible, as physicians have to balance the safety of both the mother and the fetus when making a clinical decision. The first step in approaching preeclampsia is to stabilize the patient and monitor the progression of the disease. Advise bed rest and left lateral decubitus position. You also must continuously monitor maternal and fetal condition. This includes neural vitals every hour and blood works every 6 hours. We also use antihypertensive therapy, and the goal of this therapy is to keep systolic blood pressure between 130 and 155 and diastolic blood pressure between 80 to 105. Keep in mind that ACE inhibitors are contraindicated in pregnancies. It is best to start with a beta blocker or calcium channel blocker. The goal of the anticonvulsant therapy is to prevent seizures. Use magnesium sulfate 4 grams IV bolus over 20 minutes, then IV 2 grams every hour. Magnesium blocks the NMDA receptor and prevents seizures. In addition, it also has a mild antihypertensive and diuretic effect. While on magnesium, hourly neurovitals are essential to prevent magnesium toxicity. Magnesium toxicity manifests in hyporeflexia, respiratory depression, and CNS depression. If magnesium toxicity does occur, it is rapidly reversible by the administration of calcium gluconate. For all women who present with preeclampsia before 34 weeks of gestational age, use betamethasone 12 mg intramuscularly every 24 hours for 2 doses to stimulate lung maturity. No oral food should be given to patients since an emergency C-section delivery may be required when there is evident end target organ damage. Women with severe preeclampsia can still remain hypertensive for up to 3 to 6 months after delivery, and seizure risk is still present 6 weeks after delivery. Therefore, it is important to continue monitoring even after delivery. Thanks for listening to the video, and please subscribe.